me in welcoming Victoria Lazarin.
Thank you so much. It is such a pleasure to be here. I was just recalling that it has been 10 years since I was here on Cape Cod. And yes, I am returning to the Cape next month to work in a private practice. More importantly, I would like to prove that I can be taught. I wish I were as dynamic a speaker as Amy. I worry that you will be disappointed by my delivery, and I wonder if we can learn from each other. The objectives are listed in your notes, and I have no conflict for this lecture, so I'd like to start with a question. Which of the following is not a red flag for systemic involvement of a drug reaction? So your patient's got a drug reaction. What is not a red flag for systemic involvement? Presbycusis, meningism, anosmia, or mucosal bullae? The second question, what is the most common adverse cutaneous drug eruption pattern? So which pattern of rash on the skin is the most common when a patient has developed a reaction to a drug? A fixed drug reaction, urticaria, an erythematous pattern, or angioedema? And the third question, which of the following is potentially life-threatening? I know in primary care you don't think derm is dangerous. Derm can be dangerous. It can actually even be life-threatening. So, which is the most worrisome? Acute generalized xanthemus pustulosis, toxic epidermal necrolysis, or TEN, sweet syndrome, or drug rash with eosinophilia and systemic symptoms, or DRESS. I'd like to introduce you to a patient whom you all know. I met Pam this winter, 79-year-old female complaining of an itchy rash. She has a history of CVA with extraordinarily emotional outbursts. She is, on the one hand, her caregiver and her family are extremely worried. On the other hand, she's driving them crazy. Very, very traumatic, and all the time that we are interacting, she is absolutely just digging at her skin, and horrific rash where she can reach, which is primarily upper trunk and upper extremities. So she has been prescribed medications by primary care, the pain clinic, and by her pulmonologist. She has a history of allergies to codeine, oxycodone, tramadol, lisinopril, trimethoprim, all of which give her an itchy rash. Okay, big red flag right there. So when I met her, she was taking 31 medications at least once a day. So I asked her to bring in all of the medications, and her nephew brought her back, not with a bag, with a carton. She brought a carton of medicine. We put it out on the exam table and then triaged through which were generic or which were brand and which had expired and all that. And we'll come back to Pam. Oh yes, we had to separate this into two slides because there were so many drugs. Sorry. So I think the most important pearls for this entire lecture are in the next two phrases. The first is that drugs can be taken for years without an issue, and then the patient can start to react. So old friends can turn on you. Patients find that very difficult to believe. The other, probably most significant take home is that antibiotics and NSAIDs are the most common culprits, and they're probably the most common medications patients take, right? So we have to take a careful history. We always look at what is prescribed. We always, I think, ask what the patients are taking as over-the-counter supplements. But we also need to remember to ask, what are they ingesting? I've had several patients in the course of the past year end up having drug reactions to some of the flavors in the marijuana gummies that they're chewing. So we have to remember all kinds of different medications, eye drops, suppositories, and really go through a careful list, and also have a good enough rapport with the patient to get them to admit to medications that they may be taking which were not prescribed for them, but in fact were prescribed for a friend or family member, and we know that that happens regularly. So who's at risk? Patients who are at risk for cutaneous drug reactions are those who've already had cutaneous drug reactions, those who take a lot of medications, those who are elderly, those who are female. So that's PAM, right? But patients are also at risk if they are immunocompromised, if they have a viral illness. We're all familiar with the rash that ampicillin will induce in patients who have Epstein-Barr. There are certain patients who actually have a human leukocyte antigen that's going to make them more sensitive to the drugs listed here. And patients can react to either the drug or to the preservatives in the drug, the flavors in the drug, or different additives to medications, and that's where things get very complicated, particularly with supplements. So what about the pathophysiology? That's an example of a cytotoxic hypersensitivity. But reactions can be idiosyncratic, they can be non-immunologic, or they can be immune-mediated. The non-immunologic reactions are more common than allergic reactions, and the non-immunologic reactions can result from simply taking a very high dose of a medication or extended therapy with a medication, chemotherapy, for example, a toxicity to the, forgive me, the metabolites in the medication. So there's a lot to triage there in discerning what is driving the problem. We know that type 1 hypersensitivity reactions are IgE mediated, they're immune regulated, they are, they are immediate reactions, and that's when we see urticaria or hives or even angioedema. Type 2 are IgG mediated, and these are also referred to as cytotoxic. And this is when the patient can react to the drug itself, to its metabolites, or even to the red blood cell that is coated with the drug. And we are familiar with that reaction in patients who have a G6PD deficiency, who are exposed to dapsone. And they will then develop a hemolytic anemia. The type 3 is the immune complex hypersensitivity that takes minutes to days to develop, and that results from the accumulation of antigen antibody immune complexes that are deposited directly in the skin or in the blood vessels. Examples of that we see in serum sickness or vasculitis, for example. And delayed 4 hypersensitivity takes a week or two, which makes sense because the patient had to be pre-sensitized to the drug, and then there is an autobody response that develops over the course of the next week. And we see this exemplified in the more dramatic cases of erythema multiforme or Stevens-Johnson's or TEN, and we're going to look at those reactions in detail later in the presentation. So we've taken a careful history. Our clinical exam needs to really be precise. Just a pearl from dermatology. The better you are at describing what you see, sometimes you can give yourself the answer. So it's very easy to become overwhelmed with patients with rashes. True in dermatology, not just primary care. So rashes can be very complex, and it's easy to be overwhelmed. But if you step back or even step out of the room and give yourself a chance to think, and you say, well, it's itchy, but it's only affecting the upper part of the trunk. That's weird. Or the patient looks really sick, so now I have to think about rashes that are associated with people who are sick. But I kid you not, even though I do dermatology, patient came in with an eruptive dermatosis that just kept getting worse and worse, and he was so excoriated and had rubbed his skin so raw that it was really difficult to find any primary lesions. And I literally stepped out of the room, and I thought for a minute, and I said, well, they're purple or pink, and they're itchy or pruritic, and the only real primary lesions I can see are on the volar wrists, and they're kind of flat, and and they're kind of angular shaped. And I thought, hello, lichen planus, right? It's pearly, pruritic, polygonal, papular eruption. So if you talk yourself through it, a lot of times you will be able to figure out the diagnosis, even in a situation where it can be overwhelming. So what diagnostics do we do? It is perfectly reasonable to consider a skin biopsy on the condition that you and the patient clearly understand that the pathologist is not going to send you a report back saying it's his amiodarone. It's just not going to happen, okay? They can tell you that there are characteristics in the skin cells that are consistent with a drug eruption, or they can say, no, that really doesn't look like a drug eruption. That actually looks more like cutaneous lymphoma. Or actually, you know what? It's just a strange presentation of a psoriasiform exanthem, which could be psoriasis or eczema. So just be careful. A biopsy can be very helpful to you, but it's not going to tell you which drug is the problem. There are lab studies that are listed here, and you may want to consider pursuing some of those, again, if the patient is exhibiting any specific symptoms. If the patient's febrile, for example, yes, of course, you would consider doing some cultures. So what's the first step? Well, here's rocket science. The first step is to stop the offending drug, if you can figure out what it is. I saw a patient this spring who was clearly reacting to his Plavix. There was no doubt. However, his cardiomyopathy was so severe that his cardiologist categorically refused for him to come off of the Plavix until he got a different anticoagulant approved and on board into the patient. So yes, the first step is to discontinue the offending drug. The first step is in dermatology is not to send the patient back to primary care and say, they're reacting to a drug, you figure it out, which frankly is very tempting. But we got to take the high road and work together on that. So patients really need to clearly understand that once they're allergic to a drug, they're always going to be allergic. It's only going to get worse. And a lot of patients will tell you the opposite. They said, no, it was my pediatric record said that I was allergic to penicillin, but I have no idea if that's true or not. I haven't used it for years, so I'm sure it would be okay. I'm sure it wouldn't be okay. So if they're allergic to penicillin, they're not only allergic to penicillin, they're also allergic to amoxicillin, and they're likely to cross-react to cephalexin, right? So that piece of patient education is extremely important. So what did we do with Pam? I took out all of the medications that she had no idea why she was taking. So that was a good start. And then we took away all the drugs that were for conditions that she no longer had, like shingles. And then we took away, as I said, the duplicates that were generic or brand that she was taking in too much. And fortunately, she enjoyed a very healthy diet, so she didn't need to take a whole lot of these cranberry and other supplements. She was able to replace that with natural foods. So we got her down to 11 medications that she needed and clearly identified which would be PRN and explicitly wrote out for her and her caregivers under which condition she should consider taking any of those medications. Within less than a week, she was back. She was smiling. She was pleasant. She was thrilled. She was comfortable. She had no rash. She had no itch. And she thought I was absolutely brilliant. I think it was sheer dumb luck, but that's okay. So there are different patterns that these rashes will erupt in. And we'll look at a few of the most common. The very most common, the vast majority of patients who are experiencing a drug reaction are going to have an exanthematous. Goodness, that didn't come out. Erythematous eruption. A red rash. So over 95%. So the vast majority are going to, I don't know, I can't say that today. It's the eruption that looks like measles, right? So the vast majority are going to have this eruption, and the vast majority are going to have that eruption within a week of taking the offending agent. So they have itchy red papules, and from rubbing or scratching or over time, they can become confluent macular eruptions. Interestingly, the rash will spare the central face in adults, but it will always affect the central face in children. So these morbilliform or measles-like eruptions may include systemic symptoms like low-grade fever, joint pain, chills, at which point it becomes really difficult to discern whether that's a viral exanthem, right? It's got a rash and some low-grade systemic symptoms. When that is the case, a lot of times you have to expand your differential. So in adults, that differential may include acute generalized exanthematous pustulosis, or AGEP. It could include graft versus host. In children, the differential would include juvenile arthritis or Kawasaki disease. So if there is that overlap and you're not quite sure of whether or not you're dealing with a viral exanthem, then these are some of the exams that you might want to consider. The list of contributory medications for erythematous eruptions is really extensive, so I've listed those in your notes for your access. So urticaria, or hives, is another common reaction to medications or to any kind of assault that can come from the environment, think bee sting. Acute spontaneous urticaria is mast cell mediated, and that develops patients with acute spontaneous urticaria have a very rapid onset of wheals. The chronic spontaneous urticaria is a diagnosis of exclusion once that has been persistent for over 6 weeks. And chronic idiopathic urticaria is a non-immunologic event, so that can be classified based on the predominant stimulus. So some patients actually start to respond to water or to heat, or construction workers can start to react to the vibration of the heavy machinery they use. If I were to lean on this podium for the rest of my talk, I would develop hives here because I'm sensitive to pressure urticaria. So those urticarias will be defined by the triggering source. So in urticarial eruptions, the lesions appear very quickly. They last for less than 6 weeks, and they'll resolve spontaneously. Angioedema may or may not be associated, but if angioedema develops on its own, that is more worrisome. Usually you would expect the patient to have hives in addition to the injection erythema edema of an angioedema eruption. So again, there may be systemic symptoms, and that may be associated with an internal issue, thyroid issue, hepatitis issue. Only about 6% of urticarias result from drugs. The majority are actually idiopathic, but many can erupt from infection as well. Again, if there is an underlying condition that you suspect, we've got some labs listed here that you may want to consider to fine-tune your differential. It's an example of angioedema, of course worrisome in an elder. And angioedema, as I mentioned, is swelling of the subcutaneous tissues in what is obvious, and that is the mucosa or the skin, but don't forget that that also includes the respiratory and GI tracts. So the patient can end up in a life-threatening reaction when angioedema becomes severe. We're familiar with that in children who have severe peanut allergies, for example, but other bee stings, blood transfusions, any of those exogenous or endogenous triggers can result in angioedema. When it's medication, again, it's antibiotics and NSAIDs that are the most common culprits. And there are less common drug reaction patterns that we'll take a look at. This is a patient of mine whom I saw many years ago, so I can no longer remember what she took, but I assume it's an NSAID because she would only take it periodically, and whenever she took it, she would get that red targetoid eruption at her chin. So fixed drugs are well demarcated. They're red to dusky red patches or plaques. They appear pretty quickly, within minutes to days of the offending agent. And we know that there are certain body locations that are predisposed to getting fixed drug reactions, notably the glans penis, but also periocular and perioral, and also mucosal tissue is more likely to react. And AGEP is acute generalized exanthematous pustulosis, and I had to give you a Google slide because I've actually never seen it. It's unusual. Has anybody here seen it? It's an unusual eruption, and the good thing is that it has an unusual presentation. So the patients have these pustular eruptions that are surrounded by erythema, but they're also sick. So that's very helpful. Those patients will develop a high fever and leukocytosis, so a strange rash and a strange presentation, and they initially develop in a strange location. So initially those little pustules will develop all over the face and in the intertriginous areas. So that's weird. This is weird looking rash and a weird presentation, and patients don't feel well. So that makes sense that that's something you're going to work up with more labs and likely a biopsy to help discern HEP. Drug rash with eosinophilia and systemic symptoms historically has been referred to by DRESS. There are new acronyms, but I think that only makes things more complicated, so we'll stick with DRESS for the purpose of this talk. DRESS is unusual, and it can affect multi-organs. You've got the common responsible medications listed there. And the strange thing about DRESS is that patients can develop symptoms up to 6 weeks after they've taken the medication. Who can remember what medicine they took 6 weeks ago, right? So that your history just went out the window. That's very difficult. And that the patients can develop the morbilliform eruption on the trunk, but they have really significant facial edema. So that also is going to require some lab work to help narrow down what is causing the problem with DRESS. But again, challenging because such a long period of time may have passed since the patient was exposed to the medication. For example, a surgery, sometimes you end up going back to the total hip they had 2 months ago to try to figure out what they may have received in the hospital, to tease out some of these more unusual reactions. So the internal manifestations of DRESS can be significant in that there can be significant hepatic involvement. So it's an uncommon eruption. It's uncommon that things go south, but if they do, patients are more likely to have hepatic involvement that actually can contribute to mortality of the disease up to 10%. And the next adverse drug reactions are far more dramatic. And you may or may not have seen some of these, but we always need to be aware of the risk. So this photo is a young man who's a patient of mine who is now being cared for in rheumatology. I first met him, and he presented like this. This is exfoliative erythroderma. And the skin at his upper back that is not red is his normal skin. So in dermatology, those are called islands of sparing. So the erythroderma is clearly covering 90% of his trunk, and it affected 90% of his entire body. So it's actually life-threatening. It's so traumatic because of fluid and electrolyte imbalance and high risk for infection. That's the issue. But he did not develop erythroderma because of a drug. He developed erythroderma because of the lack of his medication. So the patient was severe psoriasis, and he had been on a biologic. He lost his insurance, lost coverage for his biologic, and as time went on, clearly the disease simply flared dramatically. But that's an example of erythroderma. So it is, as I said, potentially life-threatening eruption. It can be caused by the list of medications that you see there, but it can also be caused by PRP, pityriasis rubra pilaris, flares of psoriasis, or even flares of cutaneous T-cell lymphomas. So that's a helpful history. If you know that the patients have those underlying diseases, that may have been the problem, not the drug, but the drugs that can cause erythroderma are listed there. It is traumatic, they're miserable, and you have to start worrying if they start to desquamate or if they have lymphedema or hepatosplenomegaly. It becomes an urgent situation. This is an example of erythema multiforme. Of course, your first thought is syphilis, right? As soon as you see targetoid lesions on the palms. In erythema multiforme, the lesions are not limited to the palms. Only 10% are associated with drugs, again, NSAIDs and antibiotics, but also antiepileptics. 90% of erythema multiforme cases will be the result of infection. We see it a little bit more often in young people. They call it erythema multiforme minor if there are not mucosal involvement, erythema multiforme major if there are systemic symptoms, and mucosal involvement, which includes erythema, ulceration, bleeding, and crusting. This is an example of TEN, or toxic epidermal necrolysis. Clearly a life-threatening condition. We don't see it often, but we want to catch it as early as absolutely possible. So TEN is actually on the same spectrum as Stevens-Johnson's. They used to think that these were two different etiologies. They're not. It's the same disease. However, they are classified simply by the percent of body area affected. Stevens-Johnson's will affect less than 10% of total body surface area. TEN will affect greater than 30% body surface area. Interestingly, they've recently found that TEN is more common in certain patients who actually lack a gene that helps to detoxify drug metabolites. So that makes more sense why some people have this life-threatening reaction to Bactrim and others are absolutely fine, right? But these are the drugs on your left and infections on the right that are most commonly associated with Stevens-Johnson's, and unfortunately, they're not that unusual, right? You prescribe a whole lot of these medications. I will admit to working in primary care and being completely overwhelmed when I was shortly out of school, which was a really long time ago. And I had prescribed Bactrim for a young woman who had a UTI, and everything seemed to be going swimmingly good until my supervising physician called me in a few days later and said she's in the ER, and I thought, oh my God, I've just started working and I already killed someone. And she had a huge eruption at her labia from these. So she had a fixed drug that quickly developed into TEN from the Bactrim. I've never prescribed it ever since she survived. I didn't. The primary care just totally overwhelmed me. So there are a lot of medications that can trigger these responses. Fortunately, not a whole lot of patients have that susceptibility. But Stevens-Johnson will have a prodrome. There's a few days of sore throat, malaise, muscle aches, stinging eyes, upper respiratory infection type symptoms before they develop the targetoid lesions on the skin, and subsequently the mucosal hemorrhaging. And TEN is associated with the patient being really toxic. It's a high fever, severe pain, cardiovascular compromise, and metabolic imbalances with organ involvement. So these patients need to be rapidly hospitalized, preferably in a burn unit. So, of course, the goal is to stop the offending treatment, and most of these patients are going to require high-dose IV corticosteroids for a prolonged period of time. May also need to receive immunoglobulin. But the mortality rate for TEN actually can be as high as 40%. So it is something we want to react to very, very quickly when you see someone's skin start to desquamate. There's good reason to panic and get them into tertiary care. But there are some other dermatoses that are not allergic reactions, but they are induced by medications. So vasculitis, for example, can result from the the vessel walls themselves becoming inflamed. It can be the result of a local reaction. It can be the result of a systemic vasculitis that then subsequently flares in the skin. So it can either be a manifestation of a systemic disease or it can be a local eruption. And the important thing in vasculitis is that drug from almost any class can be the culprit and cause that. So when we are examining the patients, what we want to do is be very, very careful to do a full body exam. If the vasculitis is affecting just the pretibial region, then you're more or less safe in deducing that that is a localized reaction. But if the rash is beginning to affect the thighs or even the trunk, now you have to start worrying about a systemic reaction, in which case you're most worried about the vessels in the eyes and in the kidneys. You have listed here the medications that can most commonly trigger the flat purpura. Those are the ecchymoses. So we see those obviously in elders, patients on anticoagulants, patients who have a significant alcohol intake. But raised purpura are the thicker palpable lesions that are purple papules, and they will be more likely to be triggered by the medications listed there. And if the patient starts to develop any ulcerations or nodules, then we have to start being a lot more concerned about the possibility of larger vessels or even arterial involvement. We've got listed here for you some of the workup that you would want to consider if you are beginning to get suspicious that there may be a systemic involvement and it's not simply localized to the pretibial area. So Sweet syndrome is a neutrophilic dermatosis. We often see it in middle-aged females. These patients are also sick. They start with a fever and red plaques, and The strange thing about sweets is that it can be associated with an internal malignancy. Symptoms involved can include edema and arthralgias, but also ocular involvement. Photosensitivity, anyone who spends any time out here on the Cape sees this regularly. These are your patients who are taking hydrochlorothiazide, and as soon as the sun comes out, they immediately get a rash in any areas of skin that are sun exposed. So a photoallergy is a delayed hypersensitivity response, and that is from the patient's exposure to photoallergens, notably medications, that these patients then are exposed to ultraviolet radiation, and they develop these eczematous eruptions. Phototoxicity actually results in tissue injury that may be presented. You may see the presentation with bullae or blistering within an hour of exposure to ultraviolet radiation when they have a predisposition from certain medications that they take. And the medications, you can see the list of systemic agents, but topical agents are equally important. In dermatology, we treat sun-damaged skin with topical 5-fluorouracil or photodynamic therapy, for example, and we're actually intentionally causing a phototoxic response in order to help to lift away all the damaged precancerous lesions from the skin in order to prevent non-melanoma skin cancers. But you'll see these unusual phototoxic presentations in patients, as I said. Hydrochlorothiazide is a common culprit, diltiazem as well, but I'm sure you also have seen this in young people who are taking amiodarone, adults taking amiodarone, or young people taking minocycline for their acne, for example, will also get dermatoses from photo exposure. And this is a drug-induced lupus. Drug-induced lupus it presents in patients who do not have an underlying lupus. So it is a lupus-like presentation where they get scaly, red, arcuate papules and plaques, predominantly at sun-exposed areas, and the medications most commonly associated with this presentation are hydralazine, procainamide, and proton pump inhibitors. And we mentioned the dyspigmentation, but I think all of us are also familiar with the eruption of acne from patients taking corticosteroids, for example. So these are dermatoses that will be secondary to certain treatments, and I think quite common. But I would like to spend just a couple more minutes reviewing eruptions that can happen from chemotherapy. All of you, I'm sure, have many, many patients receiving different types of oncology medications. And it's helpful, I think, just to quickly review some of the anticipated side effects. We know that the hair and nails and skin are made up of keratinocytes. The keratinocytes have such a rapid turnover in 28 days that they're the most susceptible cells to chemotherapy. Other cells in the body are not nearly as sensitive because they're not transitioning with that rapidity at a 28-day cycle. So we know, so that's the reason why in basic chemotherapy agents that we see so many problems with hair loss or nail destruction, right? So one of the important presentations from chemotherapeutic agents is called toxic erythema of chemotherapy. And the drugs that may trigger it are listed there. So the patients can develop desquamation and post-inflammatory hyperpigmentation as a result of having been on those medications. We need to, there's the photo. We need to alert the oncologist to this, not because it's an allergic reaction. This is not an allergy. But the oncologist may want to modify the doses or the duration of treatment in patients who are developing these adverse effects. The nail dystrophy can take all different types of dystrophic or shedding or peeling or detachment, affects fingers and toes equally. And we see that really frequently with the alkylating agents, but also with the other drugs listed there. And the chemotherapy-induced acral erythema is specific to cystosine and doxorubicin and fluorouracil, and that's when patients develop a symmetrical erythema and edema with blistering and necrosis at the palms and the soles. And they will also have a decreased sensitivity in those tissues. Vitiligo is also seen, so if we look specifically at immunotherapy, the immunotherapeutic drugs are used for metastatic melanoma and for non-small cell lung cancers. And these can create a secondary pruritus or vitiligo in up to 50% of patients. I heard a lecture about this the other day, and it seems that most of the current oncologists and dermatologists would not consider treating the vitiligo because that will, the agents that we have currently to treat vitiligo are immune modulators. And so the oncologists do not want to use immune modulators that may dampen the efficacy of the targeted therapies. So we usually just would use a topical or a light treatment for the vitiligo if it's that much of an issue. Most of them were saying in that lecture that that's not the priority for the patients. They're not so worried about vitiligo at that point. And this is a very unusual presentation. Has anyone seen this kind of papillomatous eruption on a patient on targeted therapy? So it looks awful, right? So it looks like it's a bad thing. It's a good thing. I don't think the patient was thrilled, but it's a really good thing. This is a reaction that, let me go back here. There we go. This is a reaction that is caused by immunotherapy secondary to a really effective response to the drug. So when patients are having a really robust response to their immunotherapy and the cancer is abating dramatically, this is just a very curious eruption that you'll see in patients. We can actually treat this the same way that we would treat acne in a middle-aged female, and that's absolutely fine, but it's actually a great sign for her response to the immunotherapy. So this patient had a metastatic melanoma and was doing extremely well. Targeted therapies include the epidermal growth factor receptor inhibitors, and they're treating the small cell lung cancers, pancreatic, breast, colon cancers, and also metastatic basal cells and squamous cells. And the multi-targeted kinase inhibitors are treating the melanomas and the small cell lung cancers. These medications can, let me skip here, these medications can induce a reaction to, forgive me, there's a disconnect between the slide that I'm seeing and what you're seeing. So these can create the pride syndrome or that papular-pustular acneiform eruption that we were just discussing. And if we look specifically at the kinase inhibitors, these medications can actually promote the eruption of cutaneous skin cancers. Most frequently squamous cell carcinomas, as you're seeing in this photo, but also melanomas and even some internal organ malignancies. So it's just a very curious reaction to a therapy that is targeting metastatic melanoma and breast cancer and small cell lung cancer that is actually causing different kinds of skin cancers. So what's the take home? The take home is that clearly these patients need a multidisciplinary approach. You don't try to figure that out alone in the office. Bring dermatology on board. And while I think of it, do most of you have a hard time getting your patients seen in derm? Probably should have just lectured on that. Derm, first of all, is fun because it's so challenging. A lot of you are nodding off, I get that, but it's hard. It's very hard. There's a lot of overlap. And dermatologists have been aging themselves out of residencies. There are not enough dermatology residencies in the entire nation, right across the board. Many people who are going into dermatology are predominantly female at this point. Used to be male, now female. Most are looking for a balance of work-life quality. Many are starting families. Many are interested in cosmetic and procedural dermatology. So there has been a huge vacuum that has been created that is being filled by dermatology NPs and PAs. So it is a very challenging field, but it is also very validating. I worked in ICU for 10 years. Nobody lived. Dermatology, you can actually make people better. They can actually smile. It's very rewarding as a provider. But my advice to you is to spend some time, or ask your assistant to spend some time just looking up dermatology practices in your local community and take a look at their website. If they have an NP or a PA on their website, make them your friend. If you send in a referral, the secretaries, the scheduler is going to say, yeah, we'll see them in 4 months, right? If you send a note with that referral saying, I'm really concerned. It may just be a keratosis, but it also could be a melanoma. Don't want to wait 4 months. Can you help me? We all have power over our schedules and our lives, right? So we, as well as you, can always modify things so that we can get people in. But I would encourage you to get to at least find out their name of the NPs or PAs and the derm practices close to you, and they will be very happy to work with you and make sure that your patients get seen. And if they're not sure what to do, then they will bring a dermatologist on board. Thank you. I think I'm supposed to run through the questions. So very quickly, the presbycusis, which is age-related hearing loss, is not a red flag for a drug reaction. But those meningism are signs of meningitis, neck pain, low-grade fever, headache, anosmia, loss of sense of smell, mucosal boli, those can all be associated. Adverse drug reaction pattern, that's the most common, is the one I can't say, right? Erythematous or morbilliform, that way you can remember it. And which is the most potentially life-threatening? That is a trick question. It wasn't on purpose. I must have been tired. Actually, B and D are both correct. DRESS is associated with a very low risk of mortality from hepatic involvement, but our big concern is clearly TEN, or the desquamating disease that you saw in the photos. Thank you.
Thank you. Okay, we have a few questions from the audience. The first one is, can idiopathic urticaria with angioedema be present from undiagnosed or treated Lyme illness?
Excellent question. Yes, absolutely, absolutely. And that's where you may end up in a multidisciplinary team to help diagnose that patient. Derm can be helpful. An allergist will also be extremely helpful in that case. And fortunately, at least here in New England, we now have some very good specialists for Lyme disease. But yes, absolutely.
Thank you. And we also, someone wants to know how the thyroid is related to urticaria, the thyroid gland.
It's simply having, it's not in a direct association. It is because there is dysregulation that there can be a cutaneous eruption that is signaling something going on inside. So it's more, maybe that more associated to what we'll talk about after lunch, a systemic, a cutaneous manifestation of a systemic or an internal problem.